Dr. Dincy Peter. She's a professor in the Department of Dermatology, CMC Vellore, and she has got various achievements. Got the second prize for the poster on acute monocytic leukemia presenting as fever with nodular eruption, awarded the Imrich Sarkani Memorial Award by the EADV to attend the European Congress of Dermatology at Gothenburg, Sweden, received award for the best original article published in Indian Dermatology Online Journal for the article entitled Impact of Hand Eczema Severity and Quality of Life, and has got more than 15 to 20 publications over interest. Over to Dr. Dincy Peter.
We move on to the skin. I'll be dealing with occupational skin disease in healthcare workers. This will, the order by which I'll my talk will be on. And I'll define what occupational skin disease is, how does it present, and briefly about hand eczema, which is the most important occupational skin disease which affect healthcare workers, and briefly about contact dermatitis to glove and glutaraldehyde, and how do we diagnose occupational skin disease and how do we manage. Occupational skin disease is one in which workplace exposure to some physical, chemical or biological hazard has been a causal or a major contributing factor to the skin disease. And what we have to know is there should be a high index of suspicion and a knowledge of what the worker's environment is to make a diagnosis of assuming treatment. So, and our profession is the fifth high-risk occupational category, which leads on to occupational skin disease, with an annual incidence of 7.3 occupational skin disease per 10,000 workers. And the highest risk is found to be in younger people. And based on the environment or the allergens which they are exposed to, healthcare workers are divided into three groups. That is, first groups include the physicians, surgeons, medical specialists, and dental personnel. Second group, the nurses and the paramedical staff. And the third group includes mostly the office workers, office personnel, cleaners, and disinfection and sterilization area workers. And the most common occupational skin disease is contact dermatitis, which accounts for almost 90 to 94% of cases. And out of which, irritant contact dermatitis forms the 80%. And the rest include allergic contact dermatitis and contact urticaria. And what are the history we should look at when patient comes with dermatitis, whether they are exposed to any irritant or allergen in their workplace, and is there any temporal relationship between dermatitis and work, and is the dermatitis associated with a particular task, and most importantly, whether it improves when the worker is away from work in a holiday. And the clinical presentation can be either acute or chronic. Acute, when you have the symptoms can be severe itching and pain with redness, scaling, and vesicular blistering or vesiculation with papillovesicles. Chronic, when you have a thick, like fissuring and hyperkeratosis with thickening of skin, that is lichenification. So coming to irritant contact dermatitis, what is an irritant? It is a substance which induces dermatitis in anyone if applied to the skin. So the best examples can be acids, alkalis, solvents, detergents, and abrasives. Anyone who gets exposed to these things will definitely develop a injury or a burn. And the characteristic of an irritant is it only affects the site of primary contact. It doesn't spread anywhere else, unless it is an irritant dust or a vapor or a aerosol. Like in formalin, you can actually have the phase involved. And the most common group of healthcare workers which can be involved are the cleaners, sterilization area workers, kitchen and laundry workers. And again, irritant contact dermatitis can be acute when you have a acid or an alkali injury, and the other is chronic, when otherwise called a cumulative irritant dermatitis. This is as a result of multiple subthreshold insults induced by irritant. This is the commonest type of occupational skin disease. This is due to frequent use of disinfectant solution, detergents, soaps, which lead on to epidermal barrier defect. This is the commonest dermatitis seen among nurses, surgeons, and lab personnel who frequently wash their hands between each procedure or between each patient. This is a picture to show an acute irritant contact dermatitis where you can see blistering and a necrotic skin and ulceration. This is due to a caustic burn. Cumulative, where you don't have this acute changes, but you can see the skin is dry, fissured, and has got scaling. So how do we manage? It's treatment with topical steroids, moisturizers, and in case there is secondary infection, treat with antibiotics, reduce the exposure of irritants, and reduce frequency of duration of exposure if you can't eliminate the irritant, and substitute the irritant substance with less irritating chemicals, and always avoid occlusion. Before using gloves, make sure that there is no irritant between the gloves. Otherwise, it will actually increase the irritancy potent of the chemical, and avoid excessive heat and humidity at work. And hand dermatitis, again, the treatment is almost similar. Always use warm water to wash, not hot water. Use the least harsh soap or soap with lowest concentration of antibacterial agents. And better to use alcohol sanitizing emulsion between procedures if the hand is not soiled. Use water-based moisturizers liberally between procedures, and use non-latex gloves. And protect and treat hands even while away from work. At home also, get into the habit of using moisturizers. Coming to one case scenario, here we have a surgeon who has presented with erythematous lesions over the dorsal of hand and forearm. What is your diagnosis? It's quite evident. It is allergic contact dermatitis. So it's, I'm just moving on from irritant to allergic contact dermatitis. So I'll just highlight what are the points for allergic contact. It is a delayed hypersensitivity reaction. So earlier I said only like irritants only affect the site of contact. Allergic contact dermatitis can actually involve even the other areas which are not at contact. So chemical spills or exposure often initiate sensitization, and sensitization takes around 7 to 21 days. And dermatitis develop within 24 hours after the next exposure. So you need sensitization to get an allergic contact dermatitis. The common question we often encounter when patient comes with allergic contact dermatitis is, I've been exposed to the same environment for so many years, and so how can I get this now? You can get allergic contact dermatitis at any time of a person's career, ranging from a few weeks to even many years. So as I said already, not only the site of primary contact, distant sites can also be involved, and actually it can be transferred by fingertips, and usually thick skin like palms are spared. So in allergic contact dermatitis by glove, the palms are usually spared. And thin skin like around the eyes, the skin on the face and genitalia can be more involved. Contact urticaria is occurrence of wheals at the site of contact within an hour of exposure, which resolves within 24 hours. The commonest is rubber, latex, and formaldehyde. Coming little bit in details about rubber gloves, which is a very common cause for allergic contact dermatitis. It can even cause irritant dermatitis by making your hand hot and sweaty if you are using it for a longer period. And the allergic dermatitis is more due to additives like carbamates, thioureas, and mercaptobenzothiazoles. And the sites, as I've already mentioned, the wrist, the dorsal of hand can get involved, and contact urticaria can develop due to latex. And the glove powder can absorb the chemicals, and it can lead on to airborne vehicles of allergen, provoking severe respiratory reactions. So here again, if you know that you are allergic to rubber or its additives, avoid contact, and always use a medical alert bracelet if you have a latex allergy, because you can go into a severe anaphylaxis too if without knowing this you get exposed to the latex. And always use vinyl or totally synthetic rubber gloves. Even nitrile gloves are, can be used, but it is latex free but may contain additives, can cause again allergic contact dermatitis. Another chemical which we come across in healthcare is glutaraldehyde, which is used for disinfection and processing of X-ray films and fixing specimens for microscopy, electron microscopy. It is a strong irritant and sensitizing agent. It can cause skin irritation, contact dermatitis, leading on to chronic dermatitis. The most common way to prevent the dermatitis is substitute it with less toxic agents like hydrogen peroxide or peracetic acid hydrogen peroxide, and minimization of contact. There are a lot of allergens which the nurses encounter, including cetrimide, chlorhexidine, various antibiotics they load, glutaraldehyde, and even povidone iodine. The diagnosis is by detailed history and knowledge of the workplace and results of careful patch testing. If at all you suspect allergic contact dermatitis, you go for patch testing to confirm your diagnosis, and sometimes observation of the course of the disease, and in complex cases, follow-up. And management for very localized lesion, topical steroids, and steroid sparing agents like tacrolimus. If it is a generalized, you may have to go for systemic steroids. And chronic allergic contact dermatitis, you may have to use cyclosporin, azathioprine, and for hand eczema, acitretin, and even phototherapy. And a brief few words about patch testing. When you have an allergic contact dermatitis, you can go for various patch testing kits are available, and use the chemicals are applied over the back, and the site is read after 48 hours of occlusion, and you look for erythema, papules, and vesicular lesions, and depending upon the type of allergen, you can actually identify the chemicals which has caused the allergic contact dermatitis. And the control is, as already mentioned, by elimination of the implicated agent, substitution with less toxic agents, proper engineering controls and administrative control, and use of personal protective equipment. Occupational contact dermatitis is the most frequent cause of skin disease, occupational skin disease. The treatment goals should be avoidance of chronicity. All workplace contact allergens and irritant must be evaluated as the cause or contributory factor for occupational skin disease. Thank you.